All right, looks like a few more people are still trickling in, but I think we're good to go ahead and get started. So I'm Rachel. I'm sure a lot of you have heard me on these before. I'm gonna let Dr. Lindsay introduce himself in a second to talk about complex shoulder and knee surgery. Dr. Lindsay is our newest surgeon in the VSON group since we merged with VSON Alpine, and he is our newest surgeon at VSON Alpine. So please give him a warm welcome. So with that, I'm going to let him take off the conversation, but towards the end, we're going to do a Q&A section. So for those of you who don't know how the Q&A works, you can submit your questions via this chat box. You can send them to everyone, or you can send them to just the panelists and hosts, or you're more than welcome to send them via the Q&A box at the bottom of your screen, whichever you're more comfortable with. And we'll be getting to those towards the end of the session, and we will get to as many questions as we can. And of course, if you'd like to make a follow-up consultation or appointment with Dr. Lindsay or another one of our surgeons, please visit us at vsortho.com, and there you can either fill out an appointment form or contact us via one of our clinic phone numbers. So with that, I'm going to go ahead and let Dr. Lindsay take it away.
Cool. Thanks, Rachel. Everyone who tuned in, thank you very much for being here. Hopefully you'll try and teach some stuff along the way here about complex shoulder and knee surgery. So when we're talking about these, without boring anyone to death, there are a lot of different topics to talk about, and I'll kind of touch on the things that I find interesting and the things that I see both at large academic centers and here in the highly active population that we have in Crested Butte, Gunnison, and Telluride, and certainly up in Vail and Summit County as well. So I have no financial disclosures relevant to this talk. So the other day I got my business cards in the mail, and I realized on the front of them it says complex shoulder and knee surgery and fracture care. I am of course trained in sports medicine, but these are kind of the things that I have a real interest in, and I certainly hope to kind of expand on those. And what I realize is that can be kind of a big task. When I look at that card, it's like, well, what does that mean? Or what am I supposed to be taking care of? So kind of start with a brief academic history. I went to UC Davis, which is just outside Sacramento. It's a Division I college where I was a water polo player. I then went from there to CU, and I got my master's in physiology, where I actually studied motor motion in kids with autism. From there, I went to medical school in Drexel, which was in Philadelphia. It was a little bit of a difference going from Boulder to Philadelphia. And then I moved back across the country, and I went to University of Southern California, where I was at the Keck Medical Center and the Los Angeles County Hospital, which is one of the largest trauma centers on the West Coast. And then I made it back out here to where I currently am, was back in Colorado. So I was at CU taking care of the Buffs and the Avalanche last year, and whereas the accredited an AOSSM sports medicine fellowship at CU. So side note, I mentioned water polo just to answer a few quick questions so they don't come up in the question answer later. Number one, water polo is not played with horses. It is played in a pool. Number two, no matter how tall you are, I'm 6'6", and no, you don't stand on the bottom. And to answer the third question, yes, we do wear these funny little bonnet hats, and we do wear Speedos. I don't play very much anymore because I don't like hurting people's eyes with the Speedo portion. Brief personal history. I'm kind of like most of the people who I would imagine are logged in. I love where I live. I enjoy throwing myself down hilled areas on various pieces of carbon fiber and or wood. I love what I do. I love where the work I do. I love what I play. I bring my dog as many places as she's allowed to go. And I'm a recent dad, about 3 weeks. So that's what these bags are under my eyes here. That's my wife who's doing all the hard work, of course. So my areas of expertise, sports medicine, arthroscopic surgery, cartilage restoration and preservation procedure, orthobiologic and hip arthroscopy. We won't talk too much about that today, but that is something I have an interest in. Certainly, and it's a large interest in shoulder surgery, both simple and complex, in terms of instability, fracture, and arthroplasty or replacement, and fracture management, which is a big part of living in having highly active patients is dealing with fractures. And finally, is a big part of what I do is team sports coverage, and it's a big part of what it makes my job fulfilling. So let's start out with kind of just talking about general sports medicine and the knee. And, you know, the knee injuries come in kind of various flavors. There's ligamentous injuries, there's meniscal injuries, the meniscus being the shock absorber inside the knee that you see there. There's tendon injuries about the knee, and then there's cartilage injuries. So while a lot of these we can treat arthroscopically, there are certain procedures that are more involved, and kind of the further down the rabbit hole we go, the larger the procedures get. So what makes a knee injury complex? First thing we think of when we talk about sports medicine are multi-ligamentous knee injuries. So knee injuries, many people have talked about or heard about an ACL or anterior cruciate ligament injury. And some folks may even have had one or a reconstruction. And then when we start talking about the other ligaments around the knee that provide stability to the knee, that's where we start to go from kind of a simple surgery or simple injury to more complex injuries and the problems that we see and the outcomes we expect after we have to address those. Certainly those with neurovascular compromise or injury to the blood vessels or the nerves around the knee, those certainly can make it more complex. Cartilage injuries, whether they're acute or chronic, cartilage being the smooth stuff on the ends of the bones that also provides a nice gliding surface and a shock absorption aspect to the knee. Those are things that we really get worked up about. And finally, chronic injuries. So, you know, a knee injury that happens 20 years ago or 30 years ago we may not be able to provide the same options, or it may not be as straightforward of an answer when we're addressing those. So just a brief kind of tangent. What about ACL injuries? So as you can see in this picture, you don't have to be an ACL surgeon to know that probably doesn't look right. And that screw that we see in the back of the knee is going to be complex, and we're going to have to go get that, and we're going to have a long day of work ahead of us. So, you know, the spoiler alert is that ACLs can be super complex too. If you have an ACL tear, not all of them are built the same. And for those kind of reasons I described earlier. What are the kind of things that go into just an ACL injury, right? Is who tears their ACL? Is it a professional ski racer? Is it a professional soccer player? Is it a weekend warrior? Is it a high school athlete? Is it a adolescent athlete? You know, is it, you know, someone who's enjoying their retirement and they're out skiing 100 days a year and they tear their ACL. So that certainly comes into play in terms of how complex an ACL can be to reconstruct. What options do we have? We have lots of great graft options, and all of them have a good track record. And, you know, if you have an ACL tear, you've probably had the discussion about what type of graft do we want to use. And certainly that adds to the complexity of how we fix them, the mechanisms we use to fix them, and those kinds of things. How did you tear your ACL? Did you get hit by a bus, or did you fall down skiing? Were you just walking and you stepped off a curb wrong? I've seen all of those. And certainly that can add to the decisions we have to make in order to, what are we going to fix, right? And a lot of times that has to deal with what other things are torn in along with the ACL. Is there a meniscus injury? Is there a kneecap injury or patellar injury? What about the ligaments around the knee? Are those torn? All these things we gotta kind of take into consideration. So, you know, just because not everyone's ACL injury is the same. So I guess that kind of brings you to the point that, you know, knee injuries and what makes a complex knee injury is all relative, right? So you don't have to have much experience looking at an X-ray or looking at a CT scan there to know that looks like a pretty bad fracture, right? So that's a big break in the bone, and it extends into the cartilage surface. You know, it's probably exceptionally painful. All these things that certainly is going to require surgery. But sometimes there's more subtle findings. And these, to those kind of my colleagues watching this, they'll all, you know, have a groan, because this looks like an awful injury. And even though the fracture portion of this is certainly not as dramatic. What we do see is there are a lot of other subtle injuries that we know we will occur with. We're looking at the X-ray on the left there, or even if we see someone who comes into the emergency room with a picture on the right. Those are things that we get really, really worked up about. And we certainly have various classifications, and all those classifications are related to outcomes and they're related to the surgeries we have to do. But you can see that sometimes the ACL plus the other ligaments around the knee plus fractures, all of a sudden we're making a lot of surgical decisions, and those are certainly all coming to play. Especially when we're talking about ligamentous injuries, we have to go back and we have to talk a little bit about the meniscus, right? So the meniscus is a super important shock absorption structure inside the knee. And I can tell you, there's kind of a generic picture up there on the top right, but I can tell you both of those tears there they definitely give us pause. They definitely are ones that we never like to see in patients, but we know we have tricks and procedures to fix them. But it is really important for us to get that meniscus back to as healthy as we can. So then you start getting down, the complexities start to come with, well, how do we treat these meniscus tears? What do we do with meniscal injuries? How much should we take? So this is a quote from an article that was written in 1923, where they looked and they realized, well, if we take a lot of the meniscus, we start to find out that people start to have symptoms associated with those who have osteoarthritis. And that's been proven time and time again. So while not every a meniscus tear requires surgery, or every meniscus tear requires debridement or removing that tear, we certainly we like to be meniscus savers. We like to we know that we can increase the forces that the cartilage sees inside the knee by a lot if we start taking away more and more of the meniscus, right? So where does the surgical decision making come in, and really who needs a trim, right? So you may have heard folks, they say, oh, we got to clean up the meniscus, or I got to trim of the meniscus for small tears that we know are not really going to jeopardize the function of the knee, versus who needs something really complex like a meniscal transplant, where we take a donor meniscus and a piece of bone, with or without a piece of bone, and we insert that in the knee and we anchor it, and the rehab for that is hard and takes a long time. And so, these are who do we decide to do this in, and who's a candidate for these things is really what adds to the complexity of meniscus surgery. So then when it comes down to brass tacks, we all really care about the cartilage. The cartilage is kind of the most important thing in terms of the health and longevity of the knee. That's really what we're doing a lot of reconstructions. A lot of the meniscal surgery is really to help protect our cartilage. So what if we have an acute cartilage injury, right? So one that happens kind of after an immediate injury, and we see these fairly frequently. But we evaluate based on symptoms. So things like the knee getting caught or stuck can certainly be related to cartilage injuries or meniscus injuries. When we evaluate you, sometimes people have effusions or swelling inside the knee, and a lot of times people feel that as stiffness or the inability to bend or straighten the knee. And then certainly we talk about imaging. So the first and most important thing that we get is always x-rays, and the x-rays tell us a ton of information about the health of the cartilage, and if you have a cartilage defect or injury, where can we see that? And then that really pushes us a lot of times, if we're considering a cartilage or meniscus injury, to get an MRI. And so what that MRI is showing you right there is the kind of white that you see is in the thigh bone, and that's the end of the thigh bone, the femur. And what we see is we call that edema or swelling. So imagine a bruise that you got from running into the side table. Well, that's bruise that you see underneath the cartilage inside the bone, and it can be very painful. And that can certainly change our management as well. I kind of put this kind of convoluted graft just to show that really when we talk about how do we fix cartilage injuries, they all really depend on size, right? So you can see here on the small size cartilage injuries, sometimes we can treat those with less invasive techniques. And then as we get bigger and bigger, we kind of increase the intensity or the invasiveness of the procedure. And then ultimately, if there's end stage degeneration or there's cartilage wear throughout the knee, a lot of times those are candidates for total joint replacement. So then we kind of talked about acute injuries. So let's talk about more chronic or long-standing injuries. The first thing, and you'll notice a repeating theme in this very shortly, is first thing we do is we talk about alignment. So, you know, most people either live on either the bow-legged, which is sometimes called varus, or knock-kneed, which is called valgus, end of the spectrum. So everybody lives kind of within one of the two. And some people have one leg that's valgus and one leg that's varus, or one leg that's neutral and one leg that's valgus. And people kind of come in all sorts of shapes and sizes with regards to their alignment. But just like the alignment on your car, which leads to early wear on your tires, your knee is really similar. So your alignment and the weight that goes, it really dictates where the weight goes through from weight bearing and where the cartilage sees pressure. So when we look at someone's alignment, the first thing we have to realize is, okay, well, if they're getting abnormal wear, right, just like they had on their tires, are they a candidate for something like a brace, which helps offload or unload that area of the cartilage? And that's certainly somewhere where we can start. Or do we need a procedure to go in and realign the limb? And those are sometimes called osteotomies. And that's where we make cuts in the bone and we fix them with plates and screws to realign the limb, to help offload those cartilage areas. So again, when we're talking about chronic injuries, we're going to talk about different ways we can treat them, right? So what are some methods to fix it? Again, we have to talk about alignment. So that's the number one thing. The second thing is that we can do for these small cartilage injuries, or what are called microfracture or micro drilling. And what we're doing is we're stimulating the bone and the cells underneath the cartilage to enter the joint, and they essentially turn into what we call fibrocartilage, which is similar to the cartilage that is in your knee, but it doesn't rebuild it exactly. And there have been lots of studies where we look at, oh, if we use this microfracture, this kind of minimally invasive technique, as you see here, that's done all arthroscopically through small incisions. We know that if we do this on large areas of the knee or the cartilage, it doesn't tend to go very well, and those people don't tend to do very well. But for small lesions, they actually tend to do very well. So that's kind of a decision that you know we'll talk about and we'll make if you do have this kind of injury. Again, when we talk about what are some other strategies, assessing your alignment, sometimes depending on the type of cartilage injury, we can do something called autologous grafts, meaning they come from you, and they come in a variety of shapes and sizes. This one I don't have any financial relationship with the company, but it's referred to as MACI. And then what that is we take a biopsy of your cartilage, we send it to a lab, and they regrow your cartilage cells or clones of your cartilage cells onto a matrix, and then we go back in and we literally glue that back down to the cartilage surface where the injury is. Important to understand that chronic cartilage injuries are oftentimes, especially when they're bigger, they require two surgeries. And the first surgery is to go in and really get a good evaluation of what that cartilage defect looks like. And the second surgery is to go back and replace that cartilage. Again, talking about kind of another option for folks with long-standing cartilage injuries, we address the alignment, and then sometimes we can use another graft from a donor. This is where we use a fresh donor graft that has a piece of bone on it, and we core out the area of cartilage that was damaged in the patient's knee, and then we replace it with this graft. And again, this is kind of a two surgery deal. We go in and we evaluate it, we measure it, we order the graft, and then we are able to replace that. The MRI that I show you here, you can see that there's someone who's got malalignment, right? Meaning their limb is out of alignment, but they also have areas of cartilage wear on just one side. So depending on how big that area is, they may be a candidate for something like this, where they need structural support underneath the cartilage as well. So when we're talking about cartilage injuries, what makes them complex? When I look at an x-ray like this on the left, you say, okay, well, that's a pretty normal looking knee. And you look at the one on the right and you say, well, that's not a completely normal looking knee. Even if you haven't looked at many x-rays before, you can see that you've lost a lot of the cartilage wear. So in a decision, when I see wear that looks like that, well, I say, oh, the cartilage injury is complex, sure. But what's the answer? The answer is to have them talk to Dr. Cafferty, because that patient with that x-ray there may be a candidate for total knee replacement, where we have wear in all three compartments or two of three compartments, and they may be best treated with a total knee replacement. And there's certainly complexities to total knee replacements, but sometimes, as opposed to trying to make a complex problem with a complex solution, sometimes a complex problem has a pretty simple solution. But what about everybody else who doesn't need a total knee replacement? The first thing I think about is location, location, location when I'm talking about cartilage injuries, right? So where is it? Is it underneath the kneecap, as we see on the picture on the left-hand side? You can see that they've got full thickness wear and they've got these little cysts underneath. And that tells me that the bone underneath the cartilage is not healthy and the cartilage has been worn away. But underneath the kneecap is a tricky situation. It can be sometimes difficult to access or difficult to deal with. Size matters, right? So how big that cartilage injury is. And then again, as we said, alignment. Finally, the thing that makes cartilage injuries, and certainly all knee injuries that make them complex, is that, we want to treat people. We don't treat your x-ray. We don't treat your MRI. We treat you. So, my friends in the ski patrol, if they have bad knee injuries, they may have different demands, right? And at the end of the day, your activity level, your healing potential, your other medical issues all come into play. And I hesitate when I talk to patients to tell them that, they're too old for this or too old for that, because age is really just a number. And ultimately these are kind of the biggest things that come down to when I want to treat your knee, and the strategies we have for doing that. So let's move on to my kind of the other half of this talk, and that's shoulder surgery. So shoulder surgery is something I'm just with complex knee surgery, I'm very passionate about, and have a lot of experience kind of dealing with these complex shoulder injuries. And so let's kind of go through some of those. So when we talk about arthroscopic shoulder surgery, what do we talk about? We talk about instability, meaning the ball, and typically it's referring to the ball in the socket. Rotator cuff tears, which are very common. Labral tears, the labrum's kind of a bumper made up of cartilage inside the shoulder that allows it to be more stable, and those can certainly get torn. Biceps, the biceps inserts part of one of the two heads of the biceps inserts inside the shoulder, right at the top of the labrum, and that can get torn as well. And it can either lead to pain or it can lead to deformity, as you see in this picture here, with a gentleman with a biceps rupture, that can happen spontaneously or it can happen as a result of an injury. And then there are things like acromioclavicular injuries. That's where the collarbone meets the hard portion of the outside of your shoulder, called the acromion. And those can certainly be injured, and we can fix those with arthroscopically assisted techniques, or mini open techniques where we make a small incision. So one of the most controversial and most talked about things is a rotator cuff repair or rotator cuff injuries. So these are one of the four tendons that sit around your shoulder. They provide motion to your shoulder, and they're extremely important for the stability of your shoulder. So we've been doing rotator cuff repairs for well over a century. And, and originally it used to be these big, giant open techniques, and we would drill tunnels to the bone, and we would use suture. And, we would use these kind of large open techniques. And then as time has gone on, we've moved to mini open or, even mostly arthroscopic techniques. So we have the options to do both. And I would say the vast majority in the United States are done via arthroscopic techniques. Today they're outpatient. They're mostly like arthroscopic, like I said, and we have a variety of different repair constructs and techniques that we can use to get those rotator cuff tears to get fixed, excuse me. But like with all things, there's a bit of controversy. So you may have a rotator cuff tear and you may get, you can get 5 opinions, you may get 7 answers. So that's not uncommon. There are a lot of things that we have to take into consideration. We have lots of options for those based on, again, activity level, size of the tear, location of the tear, other medical comorbidities or other medical problems. So we have things like suture repair, like we saw on the last slide. We have things like superior capsular reconstruction, where we use a graft to rebuild the top rotator cuff musculature or tendons, or to try and support the ball and socket joint. We have support grafting, or things that we can add that augment or build upon the existing tendons. And then most recently, this is a device you see in the bottom right that was just FDA approved, but that's for folks who have torn their rotator cuff and we're unable to repair them. But they're not quite ready for replacement. Not always the case, not always the best thing to use. Certainly the indications and the discussion we have regarding that device can be somewhat limited, but that's another option that we have. So the important thing to note is that our goal is to return function to the shoulder in the most reliable way possible. So while, yeah, you can certainly undergo an enormous arthroscopic reconstruction, sometimes replacement is a better option, just like in the knee. So just a brief kind of point on physical therapy. So one of the most important things, regardless of surgical intervention, is therapy, especially for the shoulder. And we know that when we're looking at physical therapy especially in rotator cuff tears, physical therapy works, right? So it's effective. This is a large multi-center study that showed that it was rotator cuff therapy for rotator cuff tears, even in full thickness tears, can be highly effective, right? So that's the most important factor there is managing patient expectations and understanding, okay, what do I want out of my shoulder, and how do I want to, what activities do I want to do? So we'll kind of move on. We'll talk a little bit about shoulder instability. So shoulder instability, if you think of the shoulder like a golf ball on a golf tee, and even if you haven't played golf, you put a golf ball on a broken tee, and it doesn't tend to stay there very well. And so we know that if we knock the golf ball off the golf tee, in this analogy from the shoulder, depending on your age and activity level, your risk of redislocating your shoulder it can go up. So what do we do for shoulder instability? Well, we typically do arthroscopic surgery. It's typically outpatient. We have a ton of different techniques, but they all typically involve some kind of anchor and repairing that labrum that we talked about earlier, because that's overwhelmingly the majority of the time, that's what's injured when you dislocate your shoulder. So the question and the complexities come into where are we repairing the labrum with a suture kind of construct, or are we rebuilding the golf tee, right? The golf tee, again, being the glenoid. So what then makes instability surgery kind of complex? And honestly, it makes it complex, but this is what really makes it interesting as well, is what about people who have dislocated multiple times? And you may know people like this, and you may have talked to people who have dislocated in their sleep. And so they get really low energy mechanisms to put their shoulder out of place. And it's very, very, very uncomfortable when that happens. So those are complex patients to treat. What about patients who have bone loss? So if you look at the example of the golf tee here, right, they've lost half the golf tee. There's no way that golf ball staying on that golf tee. So that's certainly an issue that we have to treat. What about injury to the ball or to the humeral head? But what happens when you dislocate? A lot of times, especially in younger patients, it takes a lot of force to dislocate the shoulder. So you dislocate the shoulder, and the body's natural response is to spasm the muscles and try and pull that golf ball back onto the tee. And sometimes that puts a big dent in the golf ball. So for us, that's an issue we have to address. And then finally, and honestly, probably one of the more difficult things to treat in complex instability surgery are prior surgeries. So we have patients with lots of different prior surgeries. Many times they were done via an open technique, right? Where they had a larger incision and they were all done through a large incision. And we go back and try and reconstruct things. Sometimes they have older metal anchors. We don't typically use metal anchors anymore, but it's not unheard of. And sometimes we have to go and we have to try and figure out, okay, well, how are we going to reconstruct this shoulder to give them a stable shoulder around these existing implants that are in there? Our options are, we have arthroscopic options. So we can do things like we can fill in that dent in the humerus. And that's what we're showing in the top left picture there. Sorry, it's a little blurry, but that's called the Remplasage technique. We have options for suture repair. We have our options for arthroscopic bone block technique. So that's what that is where we do it arthroscopically through small incisions, but we use either your own piece of bone, or we use a cadaver piece of bone and we rebuild the golf tee. So that's kind of a picture of what you see there. It's listed with A and B, and that's on the back of the glenoid or the golf tee, but we can certainly do it on the front as well. Those are technically challenging, but they're excellent surgeries and people do pretty well from them. And certainly it's a good option for somebody who wants to undergo, or who has bone loss and has other option, is another option for us to use. Our open surgeries, typically the most common one is what's called the Laterge technique. And it was developed by some very, very, very smart French surgeons. And it has an excellent track record. And basically what we do is we move a piece of bone with the tendons attached, and we reattach it to the front of the golf tee with usually with screws, sometimes with buttons. And that is a fantastic way to incur stability into the shoulder. Allograft bone grafting is sometimes we can use a cadaver graft and rebuild the front of the golf tee as well. So another personal favorite topic of mine is shoulder replacement. So shoulder arthroplasty, and we have options on the left there. You see that's called an anatomic total shoulder replacement, and on the right is called a reverse shoulder replacement. And the biggest difference is where's the ball and where's the tee. Who do we use this in? When do we use this? Really depends on the type of arthritis. It depends on the rotator cuff. It depends on a variety of other things. That we can definitely have discussions about when we see you for your shoulder, right? It's usually an overnight stay in the hospital, although now more and more we're doing these same day where folks go home and they're comfortable. And I'll tell you that in someone who has long-standing shoulder arthritis, one of the procedures they get the most relief from is a shoulder arthroplasty, and that's second really only to the hip. So complexities in shoulder arthroplasty, really little things can make a big difference. So on the left here, you see that's a bad fracture of the proximal humerus and also of the distal or the end of the clavicle. So all of a sudden you took what would be an otherwise fairly straightforward replacement and you add just a little bit of complexity to it, where you may need to do a bigger incision, you may need to do other things. The same is on this picture on the right, and what that arrow is pointing to is a break in the acromion. And that little tiny break can certainly make a big change in what we have to do and how we're going to replace the shoulder. Certainly, when we talk about complex things about the shoulder, we got to talk about fractures. So the proximal humerus, the top of the humerus bone, clavicle fractures, there's glenoid fractures, people break the golf tees, and scapula fractures. Those last two are typically very high energy injuries, and they're not as common, and they don't always require operation. So that's the other thing to remember about fractures about the shoulder, is that they don't always require surgery. And sometimes they can look pretty bad on the x-ray, and you may find that the shoulder surgeon you talk to, or when we see in the ED, who said, well, we can treat this without an operation. And that sounds kind of crazy based looking on the x-ray, but we know that not everybody needs an operation. And so that adds to the complexity of what we need to do and how we need to do it. So how do we fix it when we do fix it? Sometimes we can fix it with a plate and the screws. Sometimes we can fix it with the rod that goes down the middle of the bone. And sometimes, honestly, the best treatment to get folks back to having good shoulder function, and the quickest and least painful way is to do a replacement. So it's not uncommon that we see folks who have bad shoulder fractures, and the first thing we talk about is a replacement. And that's kind of unique to the shoulder. We don't always talk about that in the hip, and we don't always talk about that in the knee. But these are certainly things that we talk about in the shoulder. I'll have just a brief note on kind of clavicle fractures. So clavicle is the collarbone. Most people can, they know of somebody who's broken their clavicle, and you may know people who have not had it operated on or had it operated on. We know that while most people, even if they have clavicle fractures that are minimally displaced or they haven't moved much, can do well without an operation, we do know that that does have a large effect on the mechanics of the shoulder. So if we do have displacement of the clavicle or the collarbone, a lot of times we'll recommend surgery because it can lead to kind of long-term improvement or restoration of those shoulder mechanics. And then also, where's the clavicle broken? So if we're looking at the picture on the left, that probably has a relatively good chance of healing. Versus the clavicle fracture on the right, even though it looks much smaller and it's kind of not as irritating appearing, that fracture is much less likely to heal, and actually the injury associated with it is probably larger. And how we fix it? Usually just with a plate and the screws. So kind of in the last couple minutes, what I'll talk about first things is, in every shoulder and knee surgery, especially the complex ones, orthopedic literature and what we study is really heavily based on outcome studies. So we want to know, how are you before surgery and how do you improve after surgery? What I typically tell patients is, yeah, it's a couple extra minutes of filling out a questionnaire, but my goal really is to get objective measurements of how much you've improved. So I want to know how you were before. I want to know how you are after, at 2 weeks, at 3 months, at 6 months, at 2 years. These are really important things. And they help us learn how to better perfect our technique and our therapy protocols. And ultimately, we want to be able to contribute to orthopedics in general and say, okay, well, how are folks doing different surgeries across the country? And can we make people better? And can we do it more rapidly and more reliably? Lastly, what I typically tell patients, my job as an orthopedist, and certainly as an expert in shoulder and knee surgery, is to tell you, I'm going to give you the menu, right? We always have options. And the goal is I give you the menu, your job's to order. I occasionally along the way will explain the specials to you. And so my goal is really to help you as the patient understand, what are my options? What can I do? And really what's going to get me back to the activity level that I want to get back to. So at VSON Alpine, what are the big things that we like to focus on? One is outcomes. We want you to get back to what you want to do. And it doesn't matter whether it's walking the dog around the block or, skiing double blacks every day from now until the end of the season, right? We bring fellowship trained experts in nearly every subspecialty of orthopedics and neurosurgery. And then at the end of the day, like we're talking about the outcomes, we bring top level data and evidence-based care. And again, we're trying to get you back to where you want to be. Now we'll kind of go through questions. I think we have more in a few minutes here. On the top there, that's my email. You can always feel free to email me if you have questions or comments about stuff. I'm always happy to do that. I think the easiest way is kind of calling up, and we can always talk about consultation or talking to you. And there's via the vsortho.com website, and that's my own website, lindsaysportsmed.com, which has a lot of patient education videos and the ability to kind of chat with us and stuff like that. And lastly, trying to stay involved with social media. So VSO and myself, we kind of that's an important thing, and we oftentimes have kind of tips and stuff that we're working on and keeping you updated. So that I'll kind of take questions, and I think Rachel's going to help with that.
Yes, absolutely. So we do have a few questions in already. And again, just to remind everybody, you can submit your questions to the chat box or the Q&A box. So let's go ahead and get started. So our first question is, are bone spurs in the shoulder problematic? Is it helpful and or common to remove these spurs?
So that's a really good question. Bone spurs sometimes are directly related to old tendon injuries, or sometimes they're calcific or calcium deposits inside the shoulder, or inside the tendon rather. There was a really good article that was just published last month that said that going in and debriding them and taking them out and repairing the rotator cuff afterwards, actually folks do a little bit better. They are not inherently dangerous, but if they're irritating, sometimes going and removing them or debriding them can improve shoulder function.
Okay. Next question. Can you explain the difference from a rotator cuff injury from a deltoid muscle tear, and how are you able to repair or cure deltoid muscle tears?
So that's another good question. Sometimes they present very, very similarly. And so a rotator cuff injury, typically that's done with physical exam. So the physical exam is the first part is, okay, how do we determine whether it's a rotator cuff injury or whether it's a deltoid injury? And sometimes the waters get a little muddied, but certainly an MRI would kind of help us really delineate between the two. Deltoid injuries in terms of the tendon, the deltoid is a very large muscle, and oftentimes we don't have to surgically repair that. If we do, that's typically done with an open procedure. It's not typically done arthroscopically, but when we do that, we do an open procedure, and we would suture the tendon and then anchor it back down to the bone. But that's how you would treat depending on how big a deltoid injury was. That's how you would typically treat that. But the first thing we need to do is really, most people will come back to full strength even after a deltoid injury, even if there's tearing inside the muscle or partial tearing at the insertion.
All right. What about new technology for one, robotics, and two, using stem cells? Are they important or just marketing hype?
So that's a really excellent question, and is controversial to say the least. So from a robotic standpoint, I'll talk about that. We don't typically use a robotic assisted technology in the operating room necessarily to reconstruct when we're doing shoulder replacements. However, I will say the vast majority of the time, and certainly on all my patients, when we do shoulder arthroplasty, we use a CT scan, which is just an additional image instead of on top of your MRI. And then that gives me a 3D image, and I'm able to basically plan out the whole surgery with the implants, where they're positioned, how they're positioned, and what your post-operative range of motion could be expected, all done pre-operatively. So when we go into the surgery, sometimes we can either use guides or we can use specialized instruments to put the replacement parts in there in exactly the way. So I've essentially done the surgery before we get to the surgery. And that's, I think, where we've seen a large leap in how folks are doing, especially with shoulder replacements. In terms of stem cells, so stem cells are widely controversial, certainly in the shoulder. Most of the stem cell research in terms of the shoulder has been done and really geared towards how do we get the rotator cuff to heal better? Right now, the jury's kind of out on whether if we add stem cells to an existing repair, if we can help it. We certainly know that if we augment it, meaning we add graft to it, that can certainly help. Doesn't always have to be that way. The most important thing to understand when you're having a rotator cuff surgery, or certainly any shoulder surgery, is getting it to heal. Our goal is to get it as anatomically replaced as possible, right? So if we're doing a rotator cuff, we want to get that rotator cuff as close to as the way it was originally as we can. If we're doing an arthroplasty or a replacement, our goal is to get it to as close to the motion as your shoulder originally had before any of the injury. So stem cells to cure arthritis, for example, in the shoulder, that hasn't been proven yet. But things like PRP or using the platelets from your blood and spinning them down and trying to get some of the anti-inflammatory kind of qualities or from PRP injected in the shoulder does have some promising results.
Okay. Next question. What are major considerations in deciding between surgery to repair versus knee replacement? You showed the example of a badly damaged knee that was a better candidate for replacement, but I want to be able to play tennis in 1 to 2 weeks and do a 5K in 1 to 2 years. My impression is that repair surgery is best for an active lifestyle with occasional impact sports. Regardless of the type of surgery, I will be a good rehab patient, but I'm willing to work especially hard if I can play tennis and do an occasional 5K.
Yeah, so I think the most important part there is that you're actively engaged in rehab, and honestly, and Dr. Cafferty, who does our joint replacements, will also talk to you about this. Is that a lot of times, a knee replacement is the best that it's ever been, right? In terms of our understanding about the surgery and how to do the surgery. When you're talking about activity level, sometimes if your goal is to get back quickly and immediately, sometimes, and you have a small meniscus tear, right? Sometimes the debridement surgery is the best thing to do. But we also know that if you have extensive damage to the joint, and you have a meniscus tear that's associated with that, yeah, we can go in and we can trim that meniscus and clean it up, and that may make you feel better for a while. But ultimately, the question is how many times do you want to do that, and how do you want to treat the knee over a long period of time? I think when you're talking about playing tennis, you're talking about running and the interaction with that versus a knee replacement, that's something that is a long discussion, and our goal is when you come in, we talk about that, right? What do you want out of your knee, and how do you want it to function? And how much can a knee replacement give you versus, if you just want a quick surgery, how long will that last you? And that's kind of the discussion I like to have.
All right, next question. If you have labrum tears in both shoulders, would you operate on both in the same operation or do one at a time?
So that's a really good question. Actually, people ask that a lot. If you have labrum tears, really is the labrum tear associated with underlying other issues? So if you have tears in the biceps anchor, which can be read by the radiologist as a labrum tear. If you've dislocated both of your shoulders in the past, or you have labrum tears that are associated with arthritis, I'll tell you that the vast majority of the time, I never say never, never say always, but the vast majority of the time, we do not recommend having both shoulders operated on, mainly because it makes it hard to feed yourself. It makes it hard to go to the bathroom. And practically, it's really difficult because anything we do to the labrum, we typically put you in a sling and we limit some of your mobility afterwards. And that's really most shoulder surgeries that we do. So I tell folks that whichever one is more painful and more debilitating to you, that's the one I like to focus on, right? Because then you also get an idea of what the shoulder surgery is going to be about. And that doesn't necessarily mean you have to have the same thing on both sides, but it certainly means that you can you get an idea of what you're in for. Because shoulder surgery sometimes can be very, very hard to recover from, and there is a lot of therapy involved. Alternatively, some folks say, well, I'm right-handed and my right arm I use it for everything. And even though my left arm hurts more, I'm just so right-handed, it really makes it difficult for me to do this. And it's like, great, okay, then we're going to focus on the right arm. And to me, that's the discussion I like to have with that.
All right. Do you need an MRI to determine if there is a meniscus tear, and how bad, or can an X-ray be sufficient?
That's a really good question. And this is something that we talk about, and this gets back to that kind of menu point that I was making. To definitively make a diagnosis of a meniscus tear, you typically need an MRI. Sometimes you can use an ultrasound, but to get the highest quality image, you're going to need an MRI. However, that being said, if you have evidence of wear on an X-ray, or you have really concerning physical exam findings, sometimes we can make a good diagnosis based on those two things. As you start to wear the cartilage, or like we were talking about earlier, if you have malalignment that's pretty substantial, we kind of operate by assumption there, not meaning we don't necessarily do surgery. We'll typically not do surgery without an MRI, but you know, we can assume that there's a meniscus there just based on the way the mechanics of the knee work. So that also comes back to, does every meniscus tear need surgery? No. Sometimes if you have some wear and tear in the joint and we think you have a meniscus tear, sometimes we can go along and we can treat that based on what your x-rays look like. And if you don't improve, then we get an MRI to definitively say, okay, yeah, well, there's a meniscus tear. But I tell folks that, you know, if we're going to get an MRI, you know, if I'm pretty sure you have a meniscus tear, I'm going to get the MRI to help us decide what to do next. If we're not clear, sometimes an MRI is the best option to really help us make the diagnosis. But if the diagnosis is pretty clear, the MRI really helps us to determine what's next.
All right, we had one individual ask, what was the PT website again? I'm going to assume that's avalanchetherapy.com. Is that what we were discussing?
Yeah, so that's where it would go. The big thing for what I showed there, that PT website was actually not a physical therapy office. What it is that's from the MOON group. And the MOON group, MOON stands for Multi-Center Orthopaedics Outcome Networks, and this is a large group of academic institutions which have studied extensively the knee and the shoulder, and they've come up with wonderful protocols. And those are things that I typically refer my patients to, or our therapists to, as guidelines for what can we do for various shoulder pathology. And I think it's a great resource for going and saying, okay, well, what am I looking for in a rotator cuff tear? What am I looking for in an ACL tear? And the MOON group, it's MOON, like the moon, group, that has a lot of great resources for patients and for providers in guiding folks with shoulder and knee injuries.
All right. And then I have had really good results with Synvisc injections in my knees for over 6 years. I am sure there will come a time when it will lose effectiveness. Is the next step replacement? Not
necessarily. Again, Synvisc, that all depends on, again, what your x-rays look like and the amount of damage in there. If you're getting results with Synvisc, and Synvisc, for those on who don't know, that's a lubrication injection. It's a synthetic form of what your body naturally produced to lubricate the joint. If you're getting good results of that, you ride that wave as long as you can. Do you necessarily need a replacement? No. I always tell people that you tell me when you need a replacement. I don't tell you. So at the end of the day, if the things we want to focus on are when they start to wear off, do we have other options? Yeah, and certainly we're always happy to kind of discuss those options with you in terms of other injections if you're not ready for surgery. Sometimes arthroscopic surgery is what you'd like to do, kind of what we were talking about earlier. And sometimes, yeah, a replacement is the most reliable way to get you function on your knee after you've tried all these other things.
Right, then it looks like we have one more question. Any thoughts as to the effectiveness of PRP and Prolow injections?
So I think the effectiveness in both the knee, certainly it's more studied in the knee than the shoulder, but both the effectiveness, that and prolotherapy have certainly been shown to improve pain in the knee. PRP, I don't know offhand, I'm trying to think of a definitive study for prolotherapy in the shoulder, and I'd have to look. I don't think there is one that definitively says prolotherapy is better, but PRP, when we look at it, especially in the knee, it can have long-standing pain resolution that is equal to or better than cortisone, and sometimes lubrication injections. But I think PRP is a wonderful adjunct for folks It has good documented results for lots of different pathologies. It is not stem cells, so we're not trying to regrow anything, but we are able to take care of a lot of inflammatory issues. And when it's used in tendons, we use it for tendon damage and stuff. But I think it's a great adjunct, and it's a great treatment option for folks, and it does have good evidence behind it. So I'm a big fan of it.
And then that same person followed up and asked amniotic fluid injections.
Again, super controversial. As of right now, stem cells, amniotic fluid injections, things like bone marrow aspirate concentrate, do not have evidence that they are superior to other types of injections. So again, some of the things that we do are really, we're willing to try as many things as possible. And I think that when we're looking at orthobiologic as that's the next wave of kind of cutting edge technology that we're working towards in orthopedics. Do we have it perfect yet? No. And I think a lot of times is when we stack it up against and we randomize it against other therapies, we just don't have all the answers yet. And I think amniotic cell injection kind of falls into that category. Same with lipogenic stem cells too.
This is a good question. If I live in Dallas, Texas, and I have surgery in Vail, Frisco, or Edwards, how often would I have to come back to Colorado for follow-up?
Well, we know you want to come back to ski anyways, so that you know about that, or bike or whatever you're into, really. If you have surgery here, we are always happy to follow up with you. And I typically we like to see you back at kind of the 2-week mark to make sure the incision looks okay. So you know we'd like you to hang around for at least that long. In terms of long-term follow-up, while I think that there's no substitution for being able to sit and talk with a patient and examine the extremity, the shoulder, the knee, and whatever, the nice part is that telemedicine has really improved over this past 2 years. So I tell folks, you know, COVID wasn't good for many things, but helping us figure out how to really effectively do telemedicine, I think it has certainly done that. So, I mean, we have plenty of patients that are, you know, in Texas and Oklahoma and California or internationally, and we have the chance to follow up with them really easily via telemed. And honestly, that's a great way of doing it. You know, with the caveat that ultimately, yeah, if, you know, we do surgery, we like to see you. We like to see how you're doing, and we like to kind of see how the limb is doing and incisions and things like that. And sometimes there's no substitution for just being in front of somebody.
If it's okay, Dr. Lindsay, I want to add on to that answer. We are currently working on a VSON concierge program. We currently have one hotel in Breckenridge, but we're working on many others. And if you reach out to us directly, depending on where you want to stay, we can work with you. But we do have one very large resort in Breckenridge where we can get exclusive discounts up to 10 or 15% for you to stay if you are a VSON patient. And we're trying to work on those discounts with more hotel partnerships throughout Vail, Frisco, and Edwards in those areas. So if you reach out to us, if you're looking to get surgery with us, or you're looking to, you know, come and see us, and you're coming from out of state, or even if you're traveling from Denver, we'll work with you. We have a lot of contacts in the hospitality industry, and we will make sure you get a good deal on a local hotel, because, you know, if you're in Colorado, we don't want you to just have surgery. Like Dr. Lindsay said, we want you to enjoy all there is to enjoy here. So let us know if you're actually interested in that. Please reach out to us. I'll shoot you our email to reach out. But we can definitely get you an exclusive VSON discount on a local hotel. So make you enjoy your stay here a little bit, in addition to, you know, having surgery.
Yeah, and ultimately, you know, we have folks from all over who come to Colorado for the activities. And we have lots of folks that come here for surgery as well. And so, you know, we are happy to take care of you, and we're happy to, no matter where you live, our goal is that we're always going to try and figure out how to take the best care of you. And I think that, you know, the physicians in our group take some of the best care of folks that you can do. And I think that we're really proud of that. So we're happy to provide that to folks, no matter where they are.
Absolutely. And we want to make sure you have a fun place to stay. So we'll work with you on that for sure. So don't hesitate to reach out, please. All right, next question. How are well-aged shoulder damage dealt with old injuries? So I think how are old shoulder injuries dealt with in the best possible way? I think that's what that person was trying to say.
Yeah, I think that's kind of what we're getting at. Honestly, that's a tough question to answer. It really depends on what the shoulder injury is. So chronic or aged, if you will, shoulder injuries, if they're fractures, they may be dealt with one way. If they are rotator cuff tears that have been there for a long time and have caused destruction of the joint, sometimes a replacement is the answer. If they are dislocations that have been there for a long time, but have remained asymptomatic and they haven't bothered anybody, and they dislocated once when they were 13 and they never dislocated again. Hey, that's a shoulder injury, and yeah, you may have a labral tear, but if your shoulder never came out again, then I'm not going to go try and repair your shoulder just for the sake of repairing it. So sometimes not operating is the best option. So when I talk to patients about a chronic shoulder injury, there's lots of factors. And again, that really comes down to what are your expectations out of your shoulder, and what does your physical exam show? So what can your shoulder do, and what are the limitations that you have now? And that can really help guide our therapy.
Awesome. It looks like we had one more comment. Not really sure if it's a question, but person said, interesting that Medicare will pay for amniotic and not PRP. Not sure if you want to speak to that at all, or.
Yeah, it kind of depends. That's also, I think, somewhat location based. I typically don't offer amniotic fluid injections, even though they're paid for, because the data doesn't support them as well. And it is interesting. It's interesting that Medicare pays for a lot of things, but doesn't pay for PRP. I typically tell folks the reason that PRP has been so controversial from a payment standpoint is because PRP is one, it is drawn from you and it is manipulated in the sense that it's spun down in a big centrifuge. It's put in a tube and spun. So, and we've not ironed out how much blood do we take, how many platelets do we need, how long do we spin it, how many white blood cells are in it. There's all these kind of different factors. And honestly, different companies have different proprietary ways of preparing the PRP. And I think that's really what the big holdup is in terms of payment from a Medicare standpoint. But from a data standpoint, PRP certainly has the leading edge in terms of relief at least in the knee.
All right, we just got another question. What type of injection do you recommend for shoulder with osteoarthritis?
That's a great question. I typically tell people that cortisone injections are similar to a Band-Aid. If you have stuff you've got to do, you got a wedding to get to, you're going on a climb, you're going on a big paddle, whatever, and your shoulder is just murdering you, sometimes a corticosteroid injection with a little bit of numbing medicine is the best way to treat osteoarthritis. And that may provide you with good relief. But how long it lasts is a little more variable. Synvisc or hyaluronic acid or lubrication injections are typically not covered for injections in the shoulder. However, have I used them? Yes. And have patients had good results? Yeah, sure. So is it an option to try? Absolutely. I typically will recommend, if we're going to do one, if insurance isn't going to cover your Synvisc injection, but and they're not going to cover your PRP injection, my goal, I would lean towards PRP as an injection for shoulder osteoarthritis. There are certain indications to do arthroscopic surgery for osteoarthritis, and they have moderate outcomes, meaning that people do okay. However, that is typically not my first recommendation in terms of treatment for osteoarthritis in the shoulder. And part of that is because people who have shoulder replacements, at the end of the day, when they're ready for that, shoulder replacement patients are typically very happy, and they're happy that they did it.
All right, looks like we got another question. About how long after labrum surgery do you have to keep your arm immobilized in a sling? Do you start PT right away?
Also, that's a very good question. Personally, I kind of like to operate in terms of therapy with what I call protocols, which are guidelines for the physical therapist that we work with. By no means do I like to tell the physical therapist exactly what they have to do. They're experts in physical therapy, so I trust their judgment for a lot of that. But there are limitations. Typically, for me, when I do a labral repair, a patient is immobilized for 6 weeks in a sling, and that's limiting their range of motion. And that's because, well, I'll anchor it down and put it exactly where it needs to be. That's just a suture. Your body has to heal it. So the first part is really making sure that your body heals it and not stressing that repair. So typically it's 6 weeks. But with that being said, I make every effort to get my patients into therapy within 5 days of surgery. And that's because I think getting introduced to a therapist, making sure you can get to therapy, and making sure that you understand things like your sling and early post-op recovery, having someone who's experienced take a look at the incisions, or the wound or the dressings. I think those are invaluable. They're super, super important. And I think the therapists do a really good job of helping us with that. And I think because they're such an important part of any orthopedic surgery, I like to get patients in early, so that they meet them and they talk about, okay, this is what we're going to do, and this is the expectations we have, and these are the things we can do.
All right, and that same person followed up with more for labrum tear due to sports, overhead and impact to goalie head, and then in parentheses, lacrosse goalie, have had shoulder dislocations put back in. So I think she was just clarifying on her question specifically.
So when we're talking about like how long are you out, there's in contact athletes, I say we're not going back to contact till at least 6 months. Typically it's a little bit closer to 9 months. And there's actually kind of recent evidence that showed that at 6 months, many athletes may not be quite ready to go back to contact sports. So even though like a goalie in lacrosse isn't getting hit as much as a a field player, that's still considered a pretty high contact activity. And we know that when we look at patients who had shoulder dislocations and had them repaired, that you're being in a contact sport along with your age and a couple of other factors can really put you at risk for re-dislocation, and nobody wants that.
All right. I think that's all the questions. We do have one comment from a person who asked a couple questions earlier. She just said, thank you. I've personally had great success with PRP, Prolow for rotator cuff injury and meniscus tear, just a commitment.
That's fantastic. Yeah, that's awesome. And I think that if you find a therapy that works, that is the best way to go about it. And if you have good stuff, it's always good to hear that people are having great success with the injections, because I really think that that helps us. That helps us kind of really push the field forward.
Awesome. Well, I think that's all the questions. We did have one attendee who raised her hand. I'm going to give it a shot and allow her to talk for a second. Carol King, if you're still on, I'm going to allow you to talk if you have a question that you want to ask out loud. If you don't want to, feel free to ignore it, but I'm going to give you a second. Carol, if you're there, you can feel free to ask a question. All right, she might have already have her question answered. So, all right, everybody, we have time for a couple more questions. If anybody wants to submit one, looks like we got one more comment, not a question, just a comment. Thank you, great informative presentation. So thank you, Dr. Lindsay.
Absolutely, my pleasure.
All right, well, I think that's all the questions. Thank you so much, everybody. Thank you, Dr. Lindsay, for taking your time this evening to share a little bit of your wealth of knowledge with all of our great attendees tonight. And once again, if you'd like to make an appointment with us or with Dr. Lindsay, please visit us at vsortho.com or vsortho/alpine.com. We're happy to accommodate you however we can. If you're coming from out of state, just let us know. We have lots of hospitality partners. Once again, we're happy to hook you up with a cool discount so you can actually enjoy your stay in Colorado and doesn't just have to be centered all around your surgery. I know that's kind of tough for some people, but you know, we want to make this as an enjoyable experience as possible for all of our patients. So yeah, please visit us online and please follow up with Dr. Lindsay if you want to make an in-person consultation. Dr. Lindsay, thank you so much for your time. Do you have anything else to add?
No, thank you, everyone. Really appreciate you letting me talk, and happy to help however I can. Thank you.
All right. Thanks so much, everybody. Have a wonderful night, and please make sure you're signed up for our newsletter so you can attend our next webinar. Thanks so much. Have a great evening.